Dr. Sandeep Tandon and respected Dr. Pillai sir to kindly take their seats. In today's first session, we have the prosthetic aspects of the cortical basal implantology. I request the first speaker, we have a little shuffling today, so I request the first speaker, Dr. Faizur Rahman. Dr. Faizur Rahman would take the first lecture today, and I request the chairpersons to kindly introduce the speaker. Dr. Faizur Rahman.
Good morning, friends. It's indeed my proud privilege to introduce Dr. Faizur Rahman, the prosthodontist from Chennai. He's my classmate, incidentally, and it's indeed a pleasure for me to introduce you, Faiz.
Thank you.
He has done his IF Master and IF Teacher course from the International Implant Foundation, Munich. He was formerly faculty in Savitha University, Chennai, and Ragas Dental College, Chennai. He has undergone training in anterior ceramics, master training, ICDE, 2004, implant training, ITI Straumann in Switzerland, and CAD-CAM training from Austria in 2011. He is a wonderful prosthodontist. He runs his own lab in Chennai called the Encore Dental Lab, and he does fabulous work in dental laboratories. And he's a mainstay in our strategic implantology community.
Thank you.
Welcome, Dr. Faiz.
Thank you, Dr. Prashant. Thank you. Good morning, everybody. I've been waiting for quite some time to see you all. I would like to start with a disclaimer. All I know is that I know nothing. This was stated by Socrates many centuries ago. And after listening to all the accomplished speakers yesterday, that's the way I feel today. Today I'll speak about occlusion. Simplistically stating, occlusion is nothing but the contact of the upper and lower teeth. That's occlusion. That's it. So now to explain that, we need to look at the entire stomatognathic system, which includes the temporomandibular joint, the muscles, the bone, and finally the teeth itself. Let us look at the skull. In the skull, you have the glenoid fossa. Inside the glenoid fossa, you attach a L-shaped mandible, which has the condyle as the fulcrum. This fulcrum, if it only opens and closes, it will obstruct the airway. So nature has it that it will rotate initially and then translate downwards. This is helped by the articular disc with the synovial fluid above and below it and the muscles that are attached to it. So now this joint is enclosed in a capsule and it is purely a mechanical joint. To this, we need to attach the muscles that will help it open and close. The elevator muscles, which is the masseter, temporalis, and the medial pterygoid, and you have the lateral pterygoid and the suprahyoid muscles, which will help in closing. So the muscles in opening and the muscles in closing are different muscles, just to note. So therefore, when we make the teeth itself, you have to make sure that your teeth are in alignment with the muscles, the bone, and the temporomandibular joint also. Occlusion is just the contact between the upper and lower teeth. When we go a little more deeper into it, when the mandible comes in contact with the maxillary teeth, it stays. That stable contact, when it stops there, is the static occlusion, and when the jaw is moving, like in the chewing movements, that dynamic contact between the teeth when it is moving is called the dynamic occlusion. Okay. So now when we look at the static occlusion, the teeth, when it comes in contact